Bismillahirrahmanirrahim. Assalamu alaikum. In the last vlog, we had discussion on the overview of inflammatory bowel disease. We discussed the basic aspects of inflammatory bowel disease. What does it mean? What are its types? What about its etiology and pathogenesis? What are the main cytokines involved in the pathogenesis of inflammatory bowel disease? What's the difference between ulcerative colitis and Crohn's disease? Then we discussed how to make the diagnosis, what is the diagnostic workup, then what are the treatment goals, and what do we mean by the step-up approach in inflammatory bowel disease. And then we discussed the role of immune therapy in inflammatory bowel disease. Then we explored the role of surgery in inflammatory bowel disease. Then what's the prognosis of inflammatory bowel disease? And then the commonly missed aspects of the management of inflammatory bowel disease, like nutrition, like psychological support. And of course, we touched upon the common mistakes which are done in the management of inflammatory bowel disease, how we miss the diagnosis, how the diagnosis of the inflammatory bowel disease is delayed. So we had an overview of inflammatory bowel disease, and we made a platform. And in today's episode, we will discuss the comprehensive management of inflammatory bowel disease, and we will see what are the 4-5 main components which we need to give attention while treating the inflammatory bowel disease and managing a patient of inflammatory bowel disease. Bismillahirrahmanirrahim. Greetings from my institution. As said in the intro, today we shall discuss the comprehensive management of inflammatory bowel disease. In today's lecture, we shall unfold understanding diagnostic delay in inflammatory bowel disease, establishing goals of care in inflammatory bowel disease, medical therapy updates, and applying precision medicine in the management of inflammatory bowel disease. So we take one by one these 4 main objectives, starting from the understanding diagnostic delay in inflammatory bowel disease. What is diagnostic delay in inflammatory bowel disease? What is its significance? Diagnostic delay is a global challenge in inflammatory bowel disease, as this impacts a large number of patients irrespective of the country and the healthcare system. So in any country, there's a trend, there is a study say that diagnostic delay is observed in case of inflammatory bowel disease. Is highlighted by several studies. Diagnostic delay is strongly and directly associated with negative outcomes and poor prognosis. The persistence or recurrence of inflammation, in case the diagnosis is delayed, can result in progressive damage to the gastrointestinal tract, potentially resulting in strictures, penetrating disease, abscesses, and even dysplasia and cancer. These complications result in 50% in Crohn's disease and 15% in ulcerative colitis, and then requiring surgery within 10 years of diagnosis. The combination of the red flags index score and non-invasive biomarkers such as fecal protectin, they can help in the early diagnosis of inflammatory bowel disease. These are highly accurate in screening patients with underlying inflammatory bowel disease to be referred for further diagnostic workup and eventual early effective treatment strategies. So the red flags index score has been developed, and the fecal calprotectin, they can help the primary care physicians or even the internists to select the patients, to screen the patients if they are at the risk of inflammatory bowel disease, or if the diagnosis is likely. So refer that person, that patient, to the specialist, so the further workup is done, colonoscopy is done, biopsy is taken, and the diagnosis of inflammatory bowel disease is done in time. I need your attention. This is from the recently published article in Diagnostics 2023, and the title is "The Earlier You Find, the Better You Treat." So red flags for early diagnosis of inflammatory bowel disease. This is the lifespan. Here, this is the healthy gut, and then the IBD starts, and it may be because of the genes, genetic predisposition, microbiome viruses, environmental factors, or immune system dysregulation in single or in combo. When they happen, the IBD disease starts. Then there is subclinical inflammatory bowel disease phase, followed by clinically active inflammatory bowel disease, and then there is a late or complicated inflammatory bowel disease. So the inflammatory bowel disease course can be divided into three phases. The subclinical phase, when there is no symptoms and signs of inflammatory bowel disease, then clinically active inflammatory bowel disease, and then a complicated inflammatory bowel disease. So the window of opportunity where you can make the diagnosis and you can prevent the complications, possible complications, or delay their onset is this one: the subclinical inflammatory bowel disease and clinically active inflammatory bowel disease. And we will see in later part of this lecture that even though the attempts are being done in diagnosing these patients at the subclinical phase. But I said that in most of the patients, the diagnosis is done over here in this phase. So the complications are already happened, and what we see, a complicated disease. So this is the notion: the earlier you find, the better you treat. Again, I need your attention over here in understanding diagnostic delays. This is time to IBD diagnosis. This is the symptoms onset, and then the first healthcare contact. It may be patient that the patient is not going to a doctor or seeking the healthcare consultation. So one patient may seek the consultation earlier than the other. So at this stage, the diagnostic delay is because of the patient-related factors. And then once the patient goes to a doctor, there may be the patient diagnosis has not been made because of the doctors didn't understand, the threshold was not that low. As I said, most of the times it is said it may be IBS or just the gut infection, then specialist review, and even then, most of the times on the first contact, the diagnosis is not thought or suspected, so there is delay. So the diagnostic delay has got two components: the patient-related factors and the healthcare-related factors. And we will see this in detail just after a few seconds. So the evaluation of IBD diagnosis is then one is patient-associated delay, emergence of symptoms, but patient goes to a doctor late, so initial medical evaluation. So if it's early medical evaluation, probably the earlier will be the diagnosis, and the earlier we will catch the disease. Otherwise, there will be delay. And then interval between physician consultation and IBD diagnosis. So referral to specialist, diagnosis of inflammatory bowel disease, and this is a stepwise happening. And this is I've taken from the just a recent paper published in World Journal of Gastroenterology in 2025, and this tells us the overview that how the diagnostic delays happen in inflammatory bowel disease. So here is a patient having inflammatory bowel disease, and this is the diagnosis. Again, I have taken this from the articles published in 2012 and the 2023. So if the diagnosis is delayed, there's high risk of stricture and penetrating disease in Crohn's disease and higher risk of colectomy requirement in ulcerative colitis. And when we see the delay, it may be patient related. And what are the patient related factors? Silent disease in 30%, there may be no symptoms. Then younger age, people don't think that the IBD can happen earlier on. NSAIDs use. Patients are taking NSAIDs, painkillers, and they, for the time being, improve the symptoms. And extra-intestinal manifestation diagnosis. This is very, very important. We'll discuss this in detail very soon. Then the doctors related, the physician related risk factor is that in younger age, the threshold for diagnosis is not that low as it should be. And if it involves the small bowel involvement, then most of the time it is considered as it may be GI infections, as the IBS, or even tuberculosis. So as I said, that the extraintestinal manifestations, and they are a tricky part of the inflammatory bowel disease diagnosis. And we know these are musculoskeletal, dermatological, hepatobiliary, and eyes. In the musculoskeletal, these are arthritis and enthesitis. In the skin, it is pyoderma gangrenosum, erythema nodosum, sweet syndrome, and phthis stomatitis. And hepatobiliary manifestations are primary sclerosing cholangitis. And in the eyes, these are episcleritis, uveitis, and iritis. Just to illustrate it in more detail, this is the oral phthis ulcers. This is the sweet syndrome. This is the erythema nodosum. This is the peristomal pyoderma gangrenosum. This one. And this is the pyoderma gangrenosum. This is the episcleritis, uveitis. This is the conventional X-rays showing the bamboo spine. Then this is the plain radiograph of the ileocecal joints with bilateral sacroiliitis. Then this is the plain radiography of the sacrum with bilateral ankylosis. And this is the MRI showing the sacroiliitis, active inflammation on the left side, and chronic inflammatory changes on both sides. The chronology of extraintestinal manifestation in patients with IBD, it plays tricks. How? In this study, in 1/4 of the patients, here 25%, up to 4 extraintestinal manifestations, they appeared before the time of IBD diagnosis. This is the course of the inflammatory bowel disease. Diagnosis has been made here, and in 25%, the extraintestinal manifestation appeared before the diagnosis of inflammatory bowel disease, and in 75% after the diagnosis of the inflammatory bowel disease. The median time before IBD diagnosis is 5 months, and it ranges from 0 to 25 months. So it's a huge, huge time. Even 2 years before the diagnosis of the inflammatory bowel disease, the patient may present with extraintestinal manifestations of IBD. Then, after the diagnosis, in 75% of the cases, the first extraintestinal manifestation manifested, and this was 92 months after the diagnosis, and the median was 29 to 183 months. Remember, 30 years after diagnosis of inflammatory bowel disease, up to 50% of patients with IBD have suffered from at least one extraintestinal manifestation. So the chronology of extraintestinal manifestation should be kept in mind while dealing with the or suspecting the inflammatory bowel disease in an inpatient. And this is the preemptive interventions in IBD. As I said, there may be subclinical inflammation. Like here, this is the digestive damage. This shows the digestive damage. Here is the disease initiation. Disease has started over here. Expansion of the auto-inflammatory process. Here the disease is started. Here the disease is started like this. And then the subclinical inflammation like this, like this. Then there is a diagnosis. You diagnose a patient over here, then it's early disease. Then complications starts appearing, the stricture, fistula, abscesses, needs for surgery, again strictures. So that's a late disease. So the first is the initiation of the disease, then the subclinical disease. This is the subclinical disease time. Then it's a diagnosis in window of opportunity. When you diagnose early, you can prevent the complications. And this is a late disease that you diagnose, but the complications have happened. Here in the subclinical phase, now the attempts are done if we can prevent the clinical manifestation or if we can prevent the development of inflammatory bowel disease. So there people are studying. This is a diagram from a recently published trial in 2023, biochemical and hematological changes in the preclinical phase. And what they found, that different biochemical hematological changes in the patients with ulcerative colitis and Crohn's disease. And they said that it can tell us that if a patient is going to develop IBD in later part of the life. And again, very interesting data, again, just a paper published last year, Danish National Biobank, and the blood was taken from the newly born infants, and they checked for the inflammatory markers at birth and risk of developing inflammatory bowel disease. And what they found, that even those who are going to develop inflammatory bowel disease in the later part of their life, they have got some inflammatory markers at birth even. So there's attempts, there are studies coming on that if we can diagnose the inflammatory bowel disease, if in the subclinical phase or before the clinical manifestation of inflammatory bowel disease, what about prevention of that? So in the future, maybe we will be going for this approach. So coming to the second component, that is the establishing goals of care in inflammatory bowel disease. We know the overall disease severity, there is inflammatory burden, there is disease impact on patients, there impact of patient on disease, and the complicated disease course. And we have seen key measures for the diagnosis of or seeing the impact of IBD on patients. And since 1970, so many measures, so many parameters have been developed till now. Then the key measures of IBD activity, again, since 1970, so many indices, so many tools have been developed in an attempt to see the IBD activity. And again, in the last decade, we saw the STRIDE 1 and STRIDE 2 trial treat to target approach. We shall discuss this in detail, but this is the good review published last year, that a lot of measures have been done, and we are doing advancements in that. And we know that in these symptoms and the quality of life, the inflammatory activity, disability of the patients, the needs for hospitalization, surgery, psychological health, all these contribute to the IBD burden. So the IBD brings along with itself so many challenges: the symptom, quality of life, inflammatory activity, disability, hospitalization, surgery, and psychological health. So What should be the treatment goals in adult inflammatory bowel disease? One is the shorter term goals where reassessment is required every 6 to 12 weeks. And what are these? Symptom improvement, the biochemical response remission, and quality of life and psychological health. These are the goals which we need to assess every 6 to 12 weeks whether our treatment is on target or not. Then the intermediate goals like symptoms remission, the mucosal healing, and the quality of life. And these should be reassessed every 6 to 12 months. Then the long-term goals like reduce disability, to reduce dysplasia, and alter the natural history of the disease. And for these goals, we need to reassess the patient every 1 to 5 years. So as the disease progresses, there's the 3 sets of goals: shorter term goals, intermediate goals, and longer term goals. The STRIDE 1 and 2, the International Organization for the Study of the IBD, they published conducted the STRIDE 1, that is the selecting therapeutic targets in IBD, and they published it in 2023, conducted this and published here in 2015. And then the STRIDE 2, which they conducted in 2021 and published at that time. So just the summary of these two. This is the therapy according to the risk. There's active inflammatory bowel disease. You start therapy according to the risk of the patient. So initially there is symptomatic response, then symptomatic remission and normalization of CRP. Then comes the decrease in calprotectin to acceptable range and normal growth in children if it's diagnosed in children. Then endoscopic healing, normalized quality of life, and absence of disability. So consider but not formal targets in Crohn's disease, transmural healing. This is the ultimate goal, and in ulcerative colitis, histological healing. And we monitor this by the short-term targets, intermediate-term targets, and long-term targets. These are the short-term targets, the symptomatic response and symptomatic remission. Then this is the intermediate target, this is the long-term targets. And if targets are not reached, disease is active, then you change your therapy. This is the nutshell or conclusion of the takeaway message from the STRIDE 1 and STRIDE 2 trials. So, patients with active disease, you give therapy according to risk and follow the patient with immediate, intermediate, and long-term goals. Again, the immediate goal is symptomatic response. The intermediate is symptomatic remission, normalization of CRP, decrease in fecal calprotectin to acceptable range. Then the long term is endoscopic healing, normalization of the quality of life, absence of disability, and normal growth in children. And this is the transmural healing and histological healing. Transmural healing in Crohn's disease and histological healing in ulcerative colitis. I've taken this from the Gastroenterology 2021, and this is the beautiful summary of the STRIDE 1, STRIDE 2 trial. SPIRIT trial, the International Organization for the Study of the Inflammatory Bowel Disease, they conducted these, and this was the selecting endpoints for disease modification trials, the SPIRIT. And what they say, these were the STRIDE, the tight monitoring, and the SPIRIT. Diagnosis is made, you set the goal, then achieve best anti-inflammatory effect. Then within months, you achieve the best possible remission. And then within a year time, you change the disease course, disease modification. So these are the 3 steps of your treatment. So after we discuss the understanding diagnostic delay and establishing goals of the care, let's move to the medical therapy updates. We can divide the IBD treatment options into pre-biologic era and biologic era. The evaluation of inflammatory bowel disease treatment strategies. Initially, there was limited options. Everyone gets the same drugs, sulfasalazine and prednisolone, for each and everyone. Then came the step-up approach, patients earning their treatments by failing other conventional therapy. Patient fails, treatment therapy fails, then you go to another option. Then comes the concepts of the top-down therapy. You start with the early intensive therapy in certain high-risk patients, and then you go down as the disease is controlled. Then comes the concepts of the treat to target. Treating through treatments to achieve specific composite endpoints. So you select endpoints and then you treat that patient that way. And then comes the novel approaches like combination therapy, pulse therapy, biomarker driven therapy. So this is the way how the IBD treatment strategies has evolved over time. So choosing the IBD treatment smartly, the first is the patients. Age, you consider the age, gender, pregnancy, comorbidities, preferences, social and financial impact, cost, access, and social determinants. And all these come under the patient's factors. So you evaluate the patient factors. What is the age, what's the gender, pregnancy, not pregnancy. Then after this, you go to the disease. You evaluate the disease, the extent of the disease, activity of the disease, what's its behavior, if complications are there, what's the severity, duration, for how long the disease is there, if there are any extraintestinal manifestations, whether the patient has taken prior treatment, and what was the response of that. Then the third step is that you evaluate the drugs, the indications, which drug is indicated when, its efficacy, onset, durability, what is the target of that drug, the clearance, if the patient is diabetic, the combinations drugs, and the position and sequence. So then once you evaluate the patient properly, you do the evaluation of the disease, then the drug, then comes the safety, like in fact chances of infections, cancer, side effects, interactions. So when you choose inflammatory bowel disease, you should choose smartly and you should evaluate all these four factors: patient, disease, drug, and safety. Just a few words about the protein-based monoclonal antibodies, are the advanced drugs. It has got three components, the three types. One is anti-TNF, anti-IL-23, and anti-integrin. They were given IV or subcutaneously. They are immunogenic. They has the immunogenicity. There's a risk of antibodies. So the antibodies they develop and they can lower down the response. So the PNR versus the SNR. Remember the anti-TNF, you consider this in perianal disease, avoid this in melanoma, lymphoma, leukemia, and latent tuberculosis. So this is very important when you consider anti-TNF. This is when you consider it, and this is you should avoid. Then the anti-IL-23, likely the safest of all monoclonal antibodies. And then the gut-specific, the anti-integrins, the gut-specific, and may not work in patients having extraintestinal manifestation. Remember, these drugs are safe in pregnancy. Now, the second group, that is the small molecules, which consists of JAK inhibitors and SIP inhibitors. The JAK inhibitors and S1P molecules, the modulators, they are oral, they are given orally, there is no immunogenicity and no risk of antibodies. Here it was a risk of antibodies, risk of immunogenicity, and they were given either IV or subcutaneously. The JAK inhibitors, you should be conscious in patients with cardiac disease and VTE. And the S1P, avoid in uveitis and macular edema. It's a relatively contraindication. and in type 2 and type 3 heart blocks. And remember, these are not safe in pregnancy. So this is how you choose the IBD treatment smartly. So the concepts of de-escalation of immune therapy. The combination of infliximab and immunosuppressant therapy is a standard management strategy for patients with Crohn's disease. Concerns regarding the implications of long-term combination therapy provided the rationale for a formal clinical trial of treatment de-escalation. In patients with Crohn's disease, in sustained steroid-free remission under combination therapy with infliximab and immunosuppressive therapy, withdrawal of infliximab should only be considered after careful assessment of risks and benefits for each patient, whereas withdrawal of immunosuppressant therapy could generally represent a preferable strategy when considering treatment de-escalation. So, a study, SPARE trial regarding discontinuation of infliximab in combination therapy of Crohn's disease published in 2023. And here they were able that they could de-escalate the therapy. So now there's a chance that you can start with the aggressive and then you can go down. So this brings us to the last component of our talk today, applying precision medicine. We know the concept, there's a concept of the therapeutic ceiling in inflammatory bowel disease. There are so many trials for the maintenance therapy in Crohn's disease and in ulcerative colitis. So there's an apparent glass ceiling effect, and it appears to constrain progress towards a goal of maximal long-term healthcare related quality of life for all. What is glass ceiling? When you give a patient, 2 patients, 3 patients, we give the same drug, and the drug has that potential. In one patient, it may be effective or give the response almost 50% of its expected. In another, it may give 60%, and in another, it may give 30%. So all patients don't behave the same, and their effect, their impact, their response is lying in between what is their possible or maximal effect and what the patients in the real world has. So patients in the white space, that is called white space gap, that sits between the top of the population response curves that typically might sit around 30 to 60% mark, and the 100% target that would represent a universally effective treatment. So we see this is like so many chronic diseases, there is therapeutic ceiling. So how can we reach the 100% target and abolish the white space? So is it possible that each and every patient gets the same response? We need to reach a point where timely diagnosis of IBD leads to the rational selection of safe and convenient therapy. This is important, with the full expectation of prompt, complete, and sustained disease control, prevention of complications, and long-term restoration of quality of life. Only with advances in almost all aspects of IBD care, we can hope to break the therapeutic ceiling. And this is a good, I have taken this figure from a study published in 2022, a recent article, and this is the therapeutic ceiling. If you want to break it, you need to do the best possible way, the preclinical diagnosis, if that is done, and then if not, then the early diagnosis, then the risk stratification, then the better understanding of the pathogenesis, it is important, improved care delivery, molecular classification is very important, improved target-driven management, new therapeutic and combinations, the non-invasive monitoring, new trial designs, then these are the scientific advances, these are the clinical advances. So you have both components and you think on both. What is the scientific advances done so far and what are the clinical advances, and you combine these, and with the help of these you do the therapeutic ceiling breaking. So this is very important concepts. Evaluation of disease assessment to inflammatory bowel disease is very, very important. Now we are moving towards holistic assessment. Initially, focus on the symptoms and quality of life. Then, objective disease activity was the second one. Then, the histological activity and biomarkers, surrogate treatment targets. Then, of course, the phenotypic interactions, serological markers, dyspepsia surveillance, functional. Then, it lead to the genetic markers, epigenetic markers, and proteomic markers and gut microbes. So, with the passage of time, we are having more holistic assessment approach in the precision medicine, and this is the figure I adopted from the recently published trial in 2024. And again, the HLA DQA1 5 carriage associated with development of anti-drug antibodies to infliximab and adalimumab in patients with Crohn's disease. This trial says that when a patient was given infliximab and adalimumab, and if they were having this mutation, then they were having chance that they will develop the antibodies to these two drugs. So whether we can find out, we can select a patient who are good candidates for these drugs and who are not good candidates for such drugs. So what is the current approach to select IB therapy? Patients are assessed using clinical, endoscopic, and radiological evaluation. We know that. Then subsequent categorization results in inaccurate and heterogeneous patients phenotyping and thereby imprecise selection of IBD therapy. So this has been the conventional, the current approach. You do the clinical examination, endoscopy, and findings, and then you select which patient should be given which drugs. So what will be the future approach? Patients are assessed during a combination of clinical and molecular profiling, incorporating genetic, immunological, and microbial evaluation. Complex raw data are interpreted by osmic-based network medicines, allowing accurate molecular profiling of patient groups and informed selection of a therapeutic agent, combination therapy, observation, or novel dietary and microbial interventions. So this is the future approach. When you go for the precision of medicines, again, this is a good trial published last year. And just this year's published trial in March, the future of IBD is the endohistomics. What is it mean by that? You do the endoscopic findings, histological findings, and omics findings. And all these are the AI-enabled endohistomics integrating approach, the patient's molecular profiling, host microbiome, cross-talk characterization, outcome and therapy response prediction, identify novel therapeutic targets and agents, and this will be the personalized medicine in inflammatory bowel disease, and this is going to be the future. So, the value-based care in IBD, the low-value care means there's a diagnostic delay, mesalamine for Crohn's disease, or chronic steroid use. If your patient, or if you see a patient with these, it's a low-value care. The medium-value care, what does it mean? Symptom-based treatment algorithm. There is the step-up therapy, and lack of dose optimization. If the patient is on this approach, that is the medium value care. There is high value care. It means multidisciplinary care, treat to target approach, screening for depression and anxiety, prophylaxis, telemedicines, all these, if they are incorporated, if they are the components of the care of the IBD, this is high value care. So, treat your patient of IBD early, treat smartly, and treat deeply. If your treatment has got these three components, early treatment, smart treatment, and deep treatment, you will be hopefully getting the best results of your treatment. So with this, I end my lecture. If you find this useful, please do share it with your colleagues and do subscribe to my YouTube channel, The Medicine Made Easy by Professor Dr. Javed Iqbal FAROOQI, to watch such content and lectures on different topics. I'm trying to make it easy and make it understandable for my junior colleagues, my PGs, even medical students and young consultants. And please do share your comments in your views in the comment section below. If there are any queries, please do share your queries. I'll try to answer that, and let's continue our discussion on inflammatory bowel disease in a joint way. Thank you very much. See you in the next episode on the other aspects of inflammatory bowel disease and other aspects of the medicine. Khuda Hafiz.